Good evening and welcome. I am Lauren Gates, your host of this evening's Airway Health Solutions conversation, Origins of Malocclusion and Airway Disorders, featuring the one and only Dr. Kevin Boyd. Welcome back, Dr. Boyd. I am so excited to have you back again for another hour. I think we could have gone on for 5 hours last time with all the questions, but let's just dive right in. And I know the last time we had you on, you just came back from your BBC webinar with James Nestor, which I listened to, and this is kind of a perfect segue to go into what we're going to be discussing tonight. So why don't you fill us in a little bit about how that went, and then we can dive right into our presentation.
It was really James Nestor playing the part of interviewer, and he's just an excellent narrator. If you can't read his book, get the audio book because he's a storyteller. And he just talked a lot about the history of his book and the research he did for it, and the diving that he actually dove 300 feet down holding his breath. And then at the end, he interviewed me about my work and how it relates to his. But yeah, it was quite a thrill, the BBC. Yeah, we can send the link. I mean, post the link to all your listeners. It's really.
Yeah, I sent it out, but I'll send it out again in the follow-up email. And it's also on our Airway Health Solutions Facebook and Instagram, which I encourage everyone to join to get these tidbits now and then. But there's so much to learn from you. So why don't we just kick it off? I know the one thing that really stood out in my mind was your discussion with James Nestor, where the jaws used to be flat, where you can lay it on the table flat, and that's no longer the case. That was really a visual that really stood out.
Yeah, and I thought the BBC thing was going to be, like video. It was all audio. So I start doing this thing with the skulls. And then after when he was done, Kevin, nobody's going to see this. But oh my God, the audio was perfect. And I had no idea he was going to actually do that. I thought they'd cut it out. I could have had those skulls to show you. I did. They're in the next room, but I don't want to waste any time.
Okay.
So what do we do? You ready to go? You want me to share?
We're ready to go. I mean, we have a full hour here. Let's utilize it. You have a lot to teach and we have a lot to learn.
Yeah. Okay. Well, let's do that. And you let me know if you can, that you can see my first slide. And when you can, I'm going to click it and there's an audio with it. So you're ready to go. Okay.
We're ready to go.
Do it.
When I'm 80 years old,
when I'm 90, hopefully when I'm 100 years old,
be able to interact with things. I always worry about is being dependent on somebody.
Health, continue to be engaged and productive.
To become an old, young, active person.
Over the course of human history, most people died before the age of 10, with an exceptional few living into their 60s and 70s. Around 150 years ago, a remarkable shift occurred, and the average length of life began to increase. Every decade, about 2 years were added to average life expectancy. This trend continued in Western Europe and North America until, by the close of the 20th century, life expectancy had doubled for most people in the developed world.
And those additional 30 years of life that we added in the 20th century, we call the first longevity revolution. It was primarily improvements in public health, like clean water, sanitation, indoor living and working environments, controlled air temperature. These are all the things that created very harsh conditions for people in the early part of the 20th century. We wanted to live longer. We didn't want our children to die. We succeeded in doing this. And we got exactly what we wished for.
Today, the numbers of people living to old age and to super old age are rising around the globe. To live a long life is a monumental achievement, and longer lifespans are precious gifts for everyone. But there is another side to this story.
50% of the children born now will live naturally to over 100 years. But if we don't increase health span, what it means is that individuals are going to still succumb to cancer, heart disease, diabetes, and neurodegenerative disease at some point between their 40s and their 70s.
Developed nations are spending a growing share of their total wealth trying to hold back a fast approaching silver tsunami.
So let me reiterate, what we are in the business of doing now is not just filling cavities, not just preventing and curing gum disease. Like, that's important to do that, but they're totally preventable. And they are getting in the way of a much more important, noble cause that dentistry is being charged with now. And the American Dental Association is behind this. What we're doing when we recognize antecedents to malocclusion, save up your money for braces when you see a 4-year-old with no space between their teeth. That's like an ophthalmologist saying, save up your money for glasses when the 4-year-old is nearsighted. He won't need them until he's driving a car. I'm going to use this term one time, and then I'm going to abbreviate it. But that's bullshit. Okay, sorry to offend anybody. We have got, when we see malocclusion, it is not, certain types of malocclusion will not improve. And tonight I'm only going to be talking about the transverse dimension, but the sagittal and vertical dimensions are the same. We don't have time for it. That'll be for another talk. So I've changed the title of my talk a little bit. Origins of malocclusion and airway disorders. Malocclusion is really what we're in the business of doing. We're dentists, we're dental professionals. Airway comorbidity is something that can be mitigated or worsened depending on whether or not we identify it and treat it appropriately and timely, or if we wait and delay treatment and do retrusive mechanics, which is often what's done in orthodontics. So there's two origins that we have to talk about. One is in a single generation. That is from birth to death, or really from conception to death. We used to say the term ontogeny implied that this is when a baby is born, a cradle to grave, we called it. Well, now we know it's actually preconception till death. And then there's phylogeny. That's our species, or the human family, which goes way back to our common ancestry with chimpanzees. If you don't like that, please find a way to get over it, because it's true. It is about 0.001% different from each other in terms of our genome. And collectively, all of us are about 1.1% difference from a chimpanzee. Now, our common ancestor with a chimpanzee about 6 million years ago looks nothing like us now, nor does the chimpanzee at the zoo. That looks totally different. We've all evolved differently, okay? But they're our closest common ancestor. It's very true, okay? So what I'm talking about on the left, on your left is ontogeny. On your right is ontogeny. That's a single generation of what can happen to a person. And on the left is phylogeny. And that is really, you could go all the way back to our, last universal common ancestor, which was 4 billion years ago. Okay. But I'm going to start with anatomically modern humans, which was about 250,000 years ago. When I started this adventure, working my way to a bachelor's in my mid-50s in anthropology, they thought maybe 100,000 years is when our genome started to be pretty much identical to what it is now. Now it's up to almost 300,000 years that there's evidence that supports this. So this is what we have now. And I'm going to show you that this does not have to happen. No malocclusion needs to get to that. No kid's face needs to get like this. If we start understanding the origins of this and how things can be done, I don't claim to know everything, but I'm just saying you can get aggressive really early, and you can put up with orthodontists saying, oh, he's not an orthodontist. Oh, you're too aggressive. Yes, I'm very aggressive. No, I'm not an orthodontist. And I'm actually going to hopefully empower a lot of you that are watching this. Some of the material comes from several lectures that I've given, and the lecture is evolving like anything. It's going from simple to complex. When I started talking about this about 10 years ago, I went back to one of my first lectures, And that seems like such a complex lecture to me when I first gave it. And now it seems so simple. And that is really how natural selection works. That's how evolution works. We go from a simple state to a more complex state. This is interesting. And this is a great analogy. It's powerful. It's robust. It's medically defensible. If somebody says to you, oh, I didn't get braces until I was 13. Why don't you just wait and let it get more complex and then try to undo it? Well, that's like an ophthalmologist, the developmental ophthalmologist, they call them. They don't call them pediatric ophthalmologists, but developmental ophthalmologists. Well, I want to help some of you become developmental dentists, okay? And what happens is if they identify a kid who has myopia or hyperopia, that's nearsightedness or farsightedness, astigmatism, amblyopia, those are collectively called uncorrected refractive errors. Well, if you leave those alone, there can be brain damage. These kids have a poor quality of life. When I was a kid growing up in the 60s, I didn't see many kids with glasses, in my kindergarten, first grade class. Now you see so many of my pedo patients under the age of 6 have corrective lenses already. It's gotten way more sophisticated. This isn't something that I just had a hunch. Boy, we should start expanding transverse deficient and sagittally deficient kids at 3 and 4. This has been done for over 100 years, and it fell out of favor after the Depression and World War II. More later on that. But the same way you would correct nearsightedness in a child, you need to optimize the structure of the craniofacial and intimately connected respiratory complex. This is from 1926. Nearly all the malocclusions begin in the deciduous dentures, the temporary teeth, they called it. Preventive orthodontia should be the concern of the physician, parents, and particularly of dentists. It's a collaboration, not just with each other in dentistry, but with physicians and the parents. They are the main collaborative partner. When you learn how to manage expectations, anxiety in little kids and their parents, you got it. You're on your way. It is a big part of pediatric dentistry's curriculum. Orthodontists get none of this because why would you have to learn how to manage anxiety in treating a 4-year-old? Maybe a crossbite once in a while, but you don't do that. That's too aggressive. Kids aren't ready for that. And their parents, we don't need training in managing anxiety in little kids. Do you know the amount of didactic and clinical experiences, hours I had to spend learning childhood development and behavior guidance? I mean, you don't get out of a pedo program. Any pediatric dentists here know that. It's mainly for managing anxiety associated with restorative dentistry. Well, you know what, you guys? Try to get out of restorative dentistry. Try to make it unnecessary in your practice. It's preventable. Be tough on sugar. Don't be afraid to say, you know what? Do you know why your kid has so many cavities? Not soft teeth, not genetics. It's fermentable carbohydrates. And take the time to do it. It's true. And it's very medically defensible, scientifically supported. What I'm talking about, I still have decay in my practice, but not a lot. We do mostly this. I am doing work at the University of Arkansas. I'm an adjunct professor of assistant professor of anthropology there. I'm a visiting scholar at the Penn Museum of Anthropology and Archaeology. Mariana Evans, who's Penn orthodontic faculty. We take these skulls out of the museum that are, hundreds of years old. Some are even over 1,000 years old. And we do cone beams on them. And we compare them. And we're changing the cephalometric norms that we use to have it more anthropologically informed. Don't have too much time. I really have to go fast. There's a lot of material to cover, and I just won't be able to do it. But for later times, if there's questions, you can email me. Lauren has my email. We do answer emails. It may take a while. But look at this. 1909, Edward Augustus Bogue, MD, DDS. He went to dental school after medical school. Gradual expansion of the arches of the temporary teeth, promoting thereby nasal breathing, which, why was this not taught to me in my pedo residency? This is BS, okay? I'm not real happy about, but I'm sure, this literature is so old and it's not evidence-based. It's not based on prospective randomized trials. Do you know when prospective randomized trials came into healthcare and science? after World War II. There was no such thing as a randomized controlled trial. Controlled observational studies is what drove the whole movement of evidence-based medicine. And it happened after World War II, more later. So spreading the arches. And what happens, and what he's saying, this is before x-rays, right? Is that the crypts, okay, the root, the follicle of the permanent bicuspid, when you expand the upper arch and you move them laterally, it brings the bicuspid with it. And when you exfoliate, that bicuspid comes in where there's adequate room for the tongue. And Bogue hypothesized this. He did not have x-rays, he just witnessed it on thousands of children, treating in Paris, France, London, England, Boston, New York, and Chicago. He had practices all over the world, and he limited his practice, and he wasn't an orthodontist. There weren't orthodontists when he started doing this, to little kids under the age of 6, trying to help them breathe better. Look at this, the first expanders shortly after the end of the Civil War, right? They were using vulcanized rubber instead of acrylic. And this looks like a Hyrax or a Haas expander to me, right? Jack screws. This is another kind of fallacy that's in the orthodontic textbooks, posterior crossbite. You know, they're saying management of transverse problems, in parentheses, posterior crossbites. That's not synonymous. You can have massive transverse deficiency and not have a crossbite. So that, again, I hope that this is impressive to people. Or look at Dr. McNamara, big influence on my career since the early 90s. I taught at Michigan, didn't ever really encounter him very much, but he's one of my heroes. Orthodontists traditionally used RME, rapid maxillary expansion, to correct crossbites, but little else. And McNamara showed, and I compared his metric of between 36 and 39 millimeters at the mesiolingual cusp at the gingival junction of the upper 6-year molars. And he wasn't even talking about airway. He just said for ideal occlusion, you need to do that. Well, if you go one tooth anterior to that, go to the second bicuspid, there's something named after Dr. Bogue. They called it the Bogue number. That a kid by age 4, if they're not at least 28 millimeters between the palatal cusp, mesial palatal cusp of the upper second primary molars, they're 24 plus their age, 28 millimeters at 4 years old, and all the way up till 12, it should be between 34 and 37 millimeters. And it correlates very strongly with what McNamara has found. So another thing, this is all I'm saying, this is a study by Rose Sheets, a very well-known orthodontist in North Carolina. And she said, well, you know, transverse deficiency manifested by the presence of a posterior crossbite. It's just not true, you guys. A lot of kids have maxillary transverse deficiency that can accommodate the tongue in an upward and forward position so that the kid can be a habitual nose breather early in life. The one thing I want everyone to take, the most noble duty that we have in dentistry is to optimize a child's ability to move air through the nose habitually through wakefulness and sleep at the earliest feasible age. So it might be 13 years old if that's the first time I encounter a kid that doesn't have that space. Say they transfer here from another city. Well, 13 is the best I can do, but you know what? I'm a pediatric dentist. And I like to see kids. The Academy of Pediatric Dentistry said we should be evaluating oral health by age 1, no later than age 1. And the American Dental Association, I sit on a task force with Steve Carstensen and several other very bright visionary people that are trying to get this into the dental curriculum more later. So generally RME, and this is in the ortho literature, until the maxillary permanent first molars erupted. I even had a kid that got a second opinion from a buddy of mine. Well, he's not a buddy, he's a colleague on the North Shore in Chicago. She's an ER doc and brought her kid to him. Oh, Kevin's too aggressive. You know what? If you expand that maxilla before the 6-year molars come in, those 6-year molars are going to come in too narrow. BS. They're palatal shells. They're in the alveolus. You move those alveoli, the palatal shells apart, it's going to take all the teeth with them. I've never put a kid by expanding their upper jaw at 2, 3, 24 months of age. In 1922 in JAMA, a physician named Cohn said the ideal age to treat, and he got this from Bogue because he was influenced by him, is 24 months old, because that's when you have 20 teeth and you can put an expander on the deciduous arch. Do you think if 100 years ago they recommended expanding kids at 2.5 and everybody was putting the 6-year molars in crossbite? I mean, they'd be out of business. This went on for 50 years and then it stopped during World War II. We're reviving it. So I'm going to move on through that and tell you a little bit more about Dr. Bogue. Look at the title of some of these, and these are in medical journals and dental journals. Early treatment of malocclusion, the position of deciduous teeth, an important diagnostic symptom. Diagnostic for what? Sleep and breathing disorders. Enlargement of the nasal sinuses in young children by orthodontia. Now, you not only widen the floor of the nasal cavity when you do transverse expansion on a 3, 4, 5-year-old, you increase the sagittal depth of the bony nasopharynx. Go figure. That's counterintuitive. And I'm going to show you diagrams of that. And it's all over the orthodontic literature that this is a phenomenon that happens with transverse expansion. You introduce a reverse pull face mask to that, you get a very exaggerated response of opening up the airway. McNamara showed this back in the 90s when he wasn't really paying attention to airway. He is now. But he showed that when you expand and protract class 3 patients or before the age of 8, is that you get the whole maxillary complex. It looks like you've done an MMA surgery. It moves counterclockwise, and the posterior nasal spine comes downward and forward, and the anterior nasal spine comes forward and up. A point moves forward, more room for the tongue. The airway gets bigger. So 1860 to 1940, collaboration between ENTs. Look at this. This looks like, set up for an orthodontic surgery, for a Lafort and sagittal split. This is how Bogue designed his expanders. This is the Bogue index, 28 millimeters, plus the kids, 24 millimeters plus the kid's age, starting at age 4. You should be able to, by age 4, you should be able to put a nickel between each of the front teeth. That was, one of Bogue's little aphorisms. So what we're saying is, and here's another thing from the Bolton Brush study. This is the only longitudinal cephalometric analysis that was done starting in the early 1930s, all the way up through the 50s. And there's still attention being paid to some. Paul Newman was actually the actor, was in that cohort to begin with. But what they found was if a child's width between the tip of the upper cuspids, primary cuspids, by age 3 wasn't at least 30 millimeters, you're already deficient. And what happens is after the age of 4 or 5, intercanine width at the tips really doesn't change much. The alveolus, the bony base, gets wider, but at the tooth level. So if you see blocked out canines on a Panorex in a 4 or 5-year-old, you can tell the parents reliably that transverse dimension will never grow enough, that the distal of the unerupted upper lateral and the mesial of the unerupted upper first bicuspid, they will not travel far enough from each other to accommodate the width of a crown. And the full adult width of a canine crown, a permanent canine crown, is certainly established between 2.5 and 3 years old. It's about between 7 and 8 millimeters wide consistently, we found. And what that says is, well, when that kid, it's reliably predictable that they may need serial extraction because that cuspid is going to be ectopic or impacted. Well, no, it means there's not tongue space now in that 4-year-old. That kid needs tongue space. You make room for the tongue in a kid before the age of 6 years old, you are going to really minimize the complexity of the degree of crowding that the kid's going to have. They're still going to need, probably corrective ortho, maybe Invisalign when they're older. It doesn't mean it fails because I've expanded. It means just like an ophthalmologist will say, look, I'm going to give your 4-year-old glasses, but he may need 3 or 4 different prescriptions before he's driving a car. It doesn't mean I failed at any stage because you have to do something later. It's a great analogy. It's sound. It's robust. Talk to a developmental ophthalmologist about, how they got that way from, maybe being seeing adults instead of just kids. Look at the title of some of these talks. The laryngoscope is still called the laryngoscope. The relief of nasal obstruction by orthodontia, a plea for early recognition and correction of faulty maxillary development. 1912, 1913, persistent mouth breathing following adenoidectomies. Has anyone heard about regrowth of adenoids? Has anyone heard of one of your patients going in and getting TNA and they do really well for a while, but they still have symptoms? I published a commentary I was invited to write in the Journal of Clinical Sleep Medicine that I'll be glad to send everybody. A century of failure of TNA surgery to completely resolve sleep disorder breathing symptoms. So, and that was supposed to tell you the year, but anyway, 1922, the treatment of malocclusion should begin as early as possible, 30 months of age being considered the most favorable time. Nasal breathing does not usually follow after removal of adenoids. No spacing between deciduous teeth is an indicator for treatment. 4 years of age, a measurement of 28 millimeters between the MAC-test and bulge index. Width of the nasal floor is dependent on now they didn't know about the sagittal depth of the nasal pharynx. They didn't have x-rays. And they just figured all of the decreased nasal resistance from expansion came from the floor of the nasal cavity, which is this shared wall with the roof of the mouth. And that physicians, this should be part of a physician's exam, not just looking at the tonsils and adenoids, but they should be looking at other things. So, sorry to be repetitious. Here is the bulge index. You can buy this at Home Depot, okay? This kid's bulge index is almost 38 millimeters. Well, that kid, that's an adult who died 500 years ago. So this is very consistent with our anthropologic norm. Here, this kid is very deficient. And, it's getting a little late for this kid. You can see that, there's no canine here. It's completely blocked out. The primary canines here. Palate is usually deep and narrow. Again, you can do this on your iTero scan. You can do it on your cone beam. Again, rotated lateral, right? You even closing that diastema and re-rotating that lateral, they're going to be touching each other. The mesial of the first spine, the distal of the lateral. This 7-8 millimeter wide is 12. Well, serial extraction. Look at that kid has been tongue space deficient for years. All right. So that is really the issue. Don't focus on that. What's going to happen at 12 or not? I'm an optimized tongue space, and that will help facilitate eruption of that tooth into a better position. Again, some of you have seen me talk. You've seen my research, and Mariette, what I do with Mariana at Penn, and Rick Robley and Jerry Rose and Catherine Lewis at she's a PhD student at Arkansas. And what we found is when you really optimize this transverse dimension in a kid's upper jaw, you're also widening the posterior nares. All right. And there's some papers on this that I can show you. They're individual studies, they're case studies, they're weak levels of research, but that's all we have. You can't run a randomized controlled trial. All right. It's impossible. It would be unethical. Say you have 100 kids and they all have transverse deficiency by validated metrics, and they all have some degree of symptoms of sleep disordered breathing, whether it's snoring, bedwetting, grinding. And you say, let's take 50 of them and let's expand them. And let's take another group and not expand them. Hello, the Nazis did that. All right. That is unethical. You can't withhold a therapeutic regimen from a human study group for the purpose of trying to prove your point on a random controls evidence-based trial. It can't be done. It will never get IRB approval. If it is, it shouldn't have been. And that is just to say that 100 years of literature, because it's case studies, that would also render it impossible to get IRB approval to withhold this regimen from a kid who had disease traits. This is what I was talking about, is that this dimension here, when you transverse expand, you grow this area here. So Sorry, I didn't have the before there. You're seeing after and after. There we go. Oh, I had it. See that? That's what happens. And I've got, right now, we're putting together a retrospective analysis, and we're showing that the Bogue index, the distance, the transverse dimension between the upper second primary molars of kids who have started treatment in my practice over the last 5 years under the age of 6, we're showing we're looking for, we don't know if we're going to find it. We may find, oh, there's no correlation. A good study means that you can find out, you can support you can create data that's going to support your hypothesis or refute your hypothesis. And you know what? That's what we're going to do. We're going to randomize it. We can't randomize the trial, and it's a retrospective, and we're going to have the people measuring be blinded to the length of treatment, and we're just going to compare the statistics and see. I'm very optimistic that it's going to support our hypothesis, but I could be wrong. I'm not going to be one of the measurers because I'm the one who designed the study. So anyway, these are some objectives that when I talk now to everybody, so it kind of counts for you, and anything that when I talk, there's going to be some anthropology involved. It's at 7:30 now. I don't know. I'd like to go another 15 or 20 minutes.
Yeah, please. Absolutely. This is fascinating. There's countless pearls here that I'm going to break down this lecture into probably about 100 pearls for everybody.
Oh my gosh. Okay. So anyone want to take a stab at that? Lauren, have I told you this, or does Ben talk to you about this? Because, look, not to put Lauren on the spot, but most people don't know this. And when I started this project, okay, it was much less than what it really is. And it's up to 275 now, but let's call it 250 for sure. That's how long our genome has been pretty much close to identical to what it is now. There's been microevolutionary change, not macro. Macroevolutionary change means incorporation of a mutation. That takes hundreds of thousands, if not millions of years to be incorporated into a genome. We have microevolutionary change, like the ability to metabolize lactose after age of weaning. And that was something that is an epigenetic change that, a lot of people can drink milk after the age of 4. But you know what? The normal wild type, we were all lactose intolerant until about 7,000 years ago, which seems like a long time ago, but it wasn't. All right, ontogeny, a little definition here. That's from conception to death, birth to death, cradle to grave, okay? Phylogeny, all right? Proto-human, fully human, 200,000 plus years ago. How about not just fully human, but delightfully human? How about that? So here's your curse, Ben. I'm sorry, whoever invites me gets put up on that portrait there. So this is when malocclusion happened. This is when we created the orthodontic industry, or a need for it. And do you know how far back we go in time that life entered into the earth? The earth is 4.6 billion years old. It didn't cool off till about 4 billion years ago when it stopped being bombarded by meteors and things. Well, guess what happened? That's when life started. Last universal common ancestor. It was single cell. It was a prokaryote, but it wasn't just bacteria. It was archaea as well. And when archaea about 2 billion years ago combined with bacteria, and then when a bacteria got engulfed by a eukaryote, which is us, that became our mitochondria. This is, we didn't learn this stuff in dental school. This should be basic education. This should be pre-dental, pre-medical education. All life on Earth shares at least 2 common factors. The Krebs cycle and ribonucleic acid become deoxyribonucleic acid. Everything that has ever lived on our planet has these 2 components, these molecules, okay, to make ATP. It even went in reverse for some, before we became multicellular. So just know this, everything alive on the planet, you are not only related to monkeys, please, it's true. I don't mean to offend anybody. I don't mean to offend the monkeys by some of us, but it's just, it's true. And we need to understand how this works. And I don't mean it to be offensive to anybody's religiosity or what your faith is. It doesn't, it can be married to that. It really can. I was raised in a tradition where this really had a hard time, but oh my gosh, this is just like amazing. You guys come along for the ride here. You're not only related to chimpanzees, you're related to a blade of grass. You're related to E. coli, okay? You share a part of the genome with E. coli. Everything evolved from a simpler form. This is when we got our tongues. When fish, about 4 million years ago, not billion, started to crawl on and pull themselves from one swamp to another when there was a drought, they had to get to the net, and they used their fins to do it. Well, those fins became our forelimbs, okay? And that's called homeobox or repurposing. Another lecture that I'm sorry, I'm not quite enough literate in it yet, but I will be, as all of these things have just sort of, I've taken a deep dive in. This is the first mammal about 350 million years ago. We coexisted with the dinosaurs and reptiles. We were tiny, tiny little creatures. This is the first deciduous dentition, okay? That there was 2 sets of teeth. That didn't happen until about 350 million years ago. And then this became us. First primates, 55 million years ago, after the dinosaurs. There were mammals, but not primates, along with the dinosaurs. And the dinosaurs got wiped out 65 million years ago. We could come out to play, and we got bigger. And this is, again, Luca, your last universal common ancestor was probably an archaea, okay, combined, and that became the eukaryotes, and then multicellularity happened about 2 billion years ago. And this is what we all have in common. So this is the work we're doing at Arkansas. This is from a cemetery in England that I was allowed to inspect at the British Museum. It was actually in Winston Churchill's map rooms during World War II. It's now loaded with pre-industrial skulls. You can't go there anymore. I had no idea how lucky I was to be invited to this, but you can't go anywhere near it anymore. This is, please people realize when you're looking at your own kid, your staff's kids, and that's who I recommend you start treating, and you can't hurt them, please. You can overexpand. Well, the beauty, and I learned this from Gerald Sampson, dual trained orthodontist, pedodontist back in the 90s, is that the beauty of starting early, it will go back, it will relapse. And transverse dimension, of course, you can overexpand and tip teeth. But if you do it right, you're going to stretch this mid-palatal suture, and it doesn't take much force when you use these groups of posterior teeth, and that 6-year molar will come with it. That's BS waiting for the 6-year molars. And which
you cut out when you said the beauty of starting early. Can you just finish that sentence?
Sorry, the beauty of, and this is from Gerald Sampson, dual trained orthodontist, pedodontist in Marietta, Georgia, retired, is that the beauty of, if you don't like the way things are going when you start early, stop what you're doing and it will go back to where it was and reevaluate. If you follow certain basic principles, not rocket science, the courses that, that we're going to be doing at AHS, but also what Bill Hang does, what Jim Bronson does with ELF. There's lots of people that are doing this with different types of appliances, but the principle is all the same. You must optimize tongue space at the earliest possible age in the sagittal and transverse dimensions. That will help optimize vertical dimension more later. So measure the Bolg index. It's reliable. It's not a diagnostic. It's an index. It points to something, but you need other metrics. But it's one thing to tell you, and then you can show other metrics that show that, yes, there's not enough room for the tongue. There's no crossbite, big deal. And you will hold your own against those in your own. If you're a general dentist seeing kids, thank God for you guys. I think it's general dentists who see children are really going to change the world. Pedodontists are still pretty much locked into doing things the way they were taught in their residencies and the way that they are given permission to treat orthodontically. It's just, thank you, GPs. Thank you, pediatric dentists that want to get more aggressive and do things different than what they were taught. And the orthodontists that are willing to please move down the age at which you're going to at least recognize antecedents to later malocclusion and not just use that information to warn the parents to save up their money for braces. Fix it now. This is what we see in pre-industrial skulls, that these were silvers of 500 years ago. Look at those jaws. Look how forward those jaws are. There's stuff in the literature, in orthodontic textbooks that say that retrognathia is normal, it's common. In fact, Bill Prophet, who I admired tremendously, but in his textbook, it says that retrognathic mandibles are something that Mother Nature designed. It facilitates the cranium going through the birth canal. No, what facilitates the cranium going through the birth canal is these fontanelles folding over each other as they come through. The chin goes nowhere near the pelvis. You do not need a retrognathic mandible to negotiate the birth canal in natural childbirth. So there was no reference for that in Dr. Prophet's book, and it's just totally not, supported, at least not yet. Somebody's got something, show it to me. That's Carl Sagan from Cosmos, one of my heroes. Anyway, ontogeny, it's in a single generation. What happens in a single generation? Origins of malocclusion. Lauren, thank you for coming up with that title, because we have to know origins of malocclusion in our single generation, our patients. You heard in that first video that half the kids that you see under the age of 10 years old will live to be 100. Okay, this is a huge responsibility. Longevity is not enough. They have to stay healthy into their older ages, and things that happen in early childhood will absolutely impact that. So I'm going to try to finish up and talking about something that I just discovered called the Dunedin Study. Fascinating. I just discovered it because they were curious about what I was doing, and I got sort of invited into this realm of medicine. Robert Lustig, some of you have heard of him. I collaborate with him a lot on several different areas. It used to be just high fructose and, the obesity issue, but he's been drawn into this realm of the aging. Are people going to age quickly, or are they going to age slowly? And that has long-term consequences for health. Well, what this hypothesis, and there's lots of support for it, and it started over 50 years ago in Dunedin, New Zealand, is that how a kid is sleeping, breathing, eating, heart function, neurological function, lung function, all of those things predict how quickly they will age. Certain things that happen before the age of 9 years old are going to reliably predict if this child is going to be susceptible to getting age onset diseases in their 40s and 50s. And, say they do live to 100, then they got 50 years of crap life. So I'm going to be introducing some info about the Dunedin study as...
What if we could take a baby and watch everything that happened to them from birth to grave? If we could examine every aspect of their life, look at everything that made them who they are, their genes, their physical well-being, their personality, their emotional ups and downs, criminal convictions, relationships, illnesses, successes, failures, the lot. Then imagine if we could do that for an entire city. Perhaps we could see or uncover what it is that really makes us all who we are. That experiment has already begun.
It's probably the world's most successful longitudinal study of a general community sample ever.
The Dunedin Study is known in our field, in many fields, as a hallmark and landmark study. In 1972, a medical school from a small New Zealand city decided to take every one of the 1,037 children born that year and follow them for life. Those children have become the 1,000 most studied people in the world. For almost 4 decades, every aspect of their lives has been monitored in detail. The experiment is called the Dunedin Study, and it is now the broadest and most in-depth study of human beings in the world.
If I had a list of the publications these world-class scientists and scholars have generated, I could probably go on for hours.
It has become the richest and most productive archive of human development anywhere.
That's an amazingly successful project, no question about it.
So this is something that this is a very serious thing, people. Thank you for coming tonight. Thank you for, I'm not done. It sounds like I'm saying farewell, but this is so serious, what we're involved with and the opportunity that we have to impact not only the quality of a child's life at point of contact, but how long they will stay healthy into an extended old age. I'm a pedodontist. I'm treating 3-year-olds. I just learned about this 2 weeks ago. And I'm introducing this into my case presentations now. Parents want to know, like they've already found out what we do and they've seen the results and they have friends that come here and they're referred by their pediatrician. And, I have sort of front-loaded credibility that it wasn't always this way. I used to get in a lot of fights with people and then I stopped judging orthodontists. It's not their fault. They don't get this in their curriculum. And it really has helped me be more patient with my colleagues, but to introduce, not only am I going to do everything I can to help optimize the structure of your child's craniofacial respiratory complex as early as possible, well, this will yield not only, more room for their tongues and, their teeth may not come in straight at 12, they may need Invisalign, but it's going to be much more, less complex. But this potentially could extend your child's lifespan, and it could extend the amount of time that they stay healthy into that extended old age, the health span. So this, again, this is like, what am I showing ultrasounds for? Well, this is important. I've even got one more program, academic program, university-based, interested in studying mid-gestational ultrasounds in parents of orthodontic patients coming to their clinic, usually by the age of 10 or 12, and seeing if there's a correlation. Can we predict? And Dr. Guimeno was the first one to suggest that in utero, if a child has a retrognathic mandible and there's an angle that you can measure, it's like SNB, Selenasion B point, is that kid will be born be a neonate with a small mandible, which is often a comorbidity with sleep-related breathing disorders. I now measure these. This is part of my orthodontic workup now. I want a mid-gestational ultrasound. This is above 68 degrees. So this is actually, but we don't know. We haven't tested this hypothesis yet. And the project hasn't even been approved yet. It's in a major traditional orthodontic program. They don't necessarily like a pediatric dentist mentoring research of one of their ortho residents, so it might get thrown out, but we're going to try. So again, this is on ontogeny. When does this start? Again, the title that Lauren gave to the talk, The Origins of Malocclusion and Breathing Issues. Ontogeny, this is a kid, and this is him now. And he was the kid in that ultrasound. I was treating 4 of his siblings. The mom is a retired hygienist. Her name is Laura End in Milwaukee, Wisconsin, drove her kids down for years to me. And I treated them. And then one day she's pregnant and showing me, oh my God, do I have another patient brewing for you? And I said, let's look at this. And that's when this was maybe, 8 or 9 years ago. And that's when we came up with this idea. Has anyone heard of gestational apnea? If a child via the placenta is not getting adequate oxygen, guess what? That kid is born small or that kid dies in utero. There's one nutrient, and oxygen is a nutrient for which the mother, while she's pregnant, has priority over the fetus. It's the only nutrient. All right. Water, vitamin D, those are things that won't kill the mom, but the baby will suffer if it doesn't. So the baby gets priority if there's some shortage of some nutrient, but not oxygen. That's why the flight attendant says, put the mask on your kid first. Then, or put the mask on yourself first, then help the kid, because what happens if you pass out? You're not going to be able to help your kid. And there are lots of problems with sleep apnea. It doesn't have to be apnea. It can be just sleep disordered breathing. And look at this, class 2 malocclusion, excess overjet and overbite. These are malocclusion phenotypes that are very common in kids that are born premature and small for gestational age, preterm birth, intrauterine growth restriction can happen. So, prenatal counseling is something that's very important. It's a very valuable service that you can provide. Doesn't pay a whole lot, almost nothing. I actually have masters in nutrition and dietetics. Do you know how often I've been paid for the ADA code for diet counseling for Caries? 0. 32 years, I've never been paid a dime, but every kid gets that counseling in my practice. Prevention doesn't pay, not yet. That's another thing that Steve Carsonson has gotten the attention of the ADA. There's got to be more involvement and more support from the American Dental Association to get services and risks identified in kids. And we need to produce more data to show that this is normal. Mount Everest in utero, this is how they discovered that the PO2 of in utero, inside the uterus, is about what was hypothesized in the early 1900s atop Mount Everest. Guess what? It wasn't. It was a mile above Mount Everest.
I believe they have not been proved to be unsafe, because when, as and if, any ingredient in cigarette smoke is identified as being injurious to human health, we are confident that we can eliminate that ingredient. And I concluded from that report, it's true, the babies born from women who smoke are smaller, but they're just as healthy as the babies born from women who do not smoke.
What about the higher rate?
Some women would prefer having smaller babies.
Yeah, it's smug. I mean, can you believe that crap? That was a physician. And then they started marketing that to pregnant women. Hey, you can have a smaller kid. That was an experiment that was inadvertently done. Now I'm going to shift a little bit. The definition for early childhood caries is not something that has always been around. It wasn't until 2015 it got incorporated into the International Classification of Disease, ICD codes. It was in the Surgeon General's report. They used to call it, caries of infancy, baby bottle syndrome, bottle rot. And you know what? Medical insurance used that as an excuse to not pay hospital costs associated with oral rehabilitation of little kids who had to be put to sleep in an OR and the recovery room, and sometimes being admitted. This could have bankrupted, and most parents just said, I can't afford it. And they'd let some of the kids, there's even a kid who died, Diamante Driver, everyone's heard about him in Baltimore, died from a tooth infection because mom couldn't afford to get him into the hospital for treatment. So fetuses fail to reach their genetically predetermined growth potential, and they call that IUGR. And those babies are usually, small. Their long bones are small, so are their jaws. Okay, go figure why that isn't talked about. I don't know. Back to early childhood caries. Why would I bring this up? We're talking about malocclusion because we have the same problem in terms of identifying what is early childhood malocclusion. And we need a firm definition. Start using it, please, because you can defend it, even though it's not into the ICD-10 yet. It will be. If I have anything to do it, this is my career life's mission now, is to get this into the International Classification of Disease. Early childhood malocclusion is a malocclusion phenotype in the transverse, sagittal, and or vertical dimension that is discovered under 72 months old. Okay, that's how we got early childhood caries. It's one cavity one cavity under the age of 72 months old. That's early childhood. And if there's more than one, okay, there's more than one, that's severe. Well, I think we should do the same thing with malocclusion. And guess what? If you see transverse deficiency in the primary dentition, if you see a retrognathic mandible in the primary dentition, it will persist, it will worsen. It either already is or will become comorbidity with sleep-related breathing disorder. You can defend that in the literature, not with a prospective randomized trial. That can't exist. It never will exist. But you can, is that it won't get better. The malocclusion will not get better. Well, if all we worried about was straight teeth, then so what? Just wait till they're 12. It's not. It often is frequently a comorbidity with sleep and breathing disorders, which can render the kid susceptible to brain disease. Lowered IQ. You can knock 5-10 points off a kid's IQ if they're not sleeping and breathing well. Neurobehavioral problems. The symptoms of ADD, ADHD, often, most of them overlap with fragmented sleep in kids, sleep deprivation. Mitigate the sleep problems. And again, am I saying, boy, you fix malocclusion, you're going to fix all breathing and behavioral problems? I'm not saying that. You're taking malocclusion off the table as being contributory. And you're being proactive, you're being preventive. The malocclusion is not going to get better. I'm a dentist. I do dentistry. And I will not be criticized for practicing out of my scope of medicine, because I can say to parents and give them literature that I'm not going to promise your kids' airway and behavioral issues are going to go away, but I can give you cause for optimism, especially if you're going to do adjunctive myofunctional therapy, if you're going to start having your child eat fresh, hard, crunchy food and not drink their vegetables and eat Gerber slop, and you know, support women who want to breastfeed, encourage them to. This is really early childhood malocclusion, a crossbite. That's one single trait, and there's no complications from, you know, there's no sleep or breathing disorders. Severe, that's when you have more. You have transverse dimension, you have a deep, narrow palate, you have a retrognathic mandible. You have, look at this kid. This is one of our first ones. She had 134 apneas, 169 hypopneas, had her tonsils out, and she went down to 50. It wasn't until we expanded her that we got this kind of result from her. Her apnea went away. Go figure. This was the very first case. This changed my life. It changed my career. We're publishing in textbooks about this. We're running trials. The craniofacial.
You froze there.
Health span, lifespan. You know, 79 is about the age that we can expect to live to now, but you're going to start getting sick before that. At 63 is the average health span. What comes in, you know, by 45, COPD, maybe we can delay colorectal cancer till 70 and we'll live to it. So we only got 9 years of a crappy life. What we need to do is not only lengthen lifespan, but improve the health span. And to do that, we have to act early, okay? Who knew about this? The American Heart Association. Kids with unresolved sleep apnea will develop high blood pressure. Most of them can. They won't 100% will. But if there's a risk, why would anybody get in my way of trying to help a kid have optimal tongue space? Why would somebody try to criticize me for being too aggressive? You know, it's just, don't get in my way. That's all I'm saying. You don't have to agree with me. Please don't get in my way. In fact, well, I'll leave it alone at that. And don't outgrow it. Children with obstructive sleep apnea who don't outgrow it, watch and wait. Does that sound familiar? Anyone know about the CHAP study from CHOP, Children's Hospital of Pennsylvania? You don't watch and wait. Oh, if they don't outgrow their malocclusion. Well, most of the most traditional orthodontists in the world knows you can't outgrow a malocclusion. Of course not. But it's just reliably predicts that, you know, save up your money for braces. Don't let voids start to use up your orthodontic benefit. I've been criticized by orthodontists because I use up the lifetime orthodontic benefit, but I'm helping the kid. So whatever, hope I'm getting some of you fired up. I get more fired up the more I talk about this, obviously. So anyway, this is from the Dunedin study. I'm going to finish with this. This is what happened. They measure kids from age 3 to age 45, reliably predicting these are the kids that didn't do well on certain metrics of brain function, reliably predicted that they wouldn't do well when they were older, in their mid-40s. These kids did really well at age 3, and they also were much healthier at 45 years old. Facial aging, and this is one of this published studies that kids' faces age faster that have autistic traits. This is a composite of males and females of kids that were started at age 3 and then at 45. And look at the, now how did they measure this? I don't know. I'm just scratching the surface of this. They didn't start really measuring facial aging in kids till 12. That's when they started looking at orthodontics too, age 12. They didn't look at it in 3-year-olds. That's why they're interested in me and my data. That's what Rob Lustig got them to notice about what we're doing. Is this incorporates very well into the Dunedin study. I'm going to be a keynote in June in Seattle. I'll tell you more about it, but I have any idea why these people were interested in me. This is how a face ages. This is normal, okay? The face retracts, the bone resorbs. This is a kid I treated 10 years ago, and this is how she came to me, and I showed the mom this picture. I said, this child's face is going to age, probably prematurely if we don't get things wider and forward. Well, I have her in at least 2 textbooks now. And this is what happened, to her face. That is a much younger, and that is a face that's going to resist aging. She's in this allergy and sleep textbook, which I can send anyone a PDF if they want it. When you study older patients and they score poorly on measures, don't assume this reflects a decline of recent origin. So they looked at 45-year-olds. Oh, this must have started in their 30s. No, many gerontology measures have their roots in childhood. This is a new concept. Maybe doing this for this kid might have helped this kid resist getting apnea as an older kid. And I don't just look at structural changes. I look at behavior. We do pre-treatment and we do progress of sleep-related breathing behaviors. And every kid that we treat, this is more about the Dunedin study. Sorry, don't mean to belabor it. This is my daughter didn't know how to do this when she was old enough. She had to have him in. Here's a way to advance the maxilla if you don't want to treat kids early. And any kid who needs an MMA, the pre-surgical diagnosis, skeletal diagnosis must be MMR. By virtue, by nature of the name of it. Maxillomandibular advancement solves the problem. What must the problem be? Maxillomandibular retrusion. Has to be. Couldn't be anything else. You can do this on kids, and you can put a face mask on a kid who's not class 3. They can be class 1 or even class 2. You make the class 2 worse, and you help that maxilla come forward. McNamara showed this, is that it looks like an MMA surgery, counterclockwise rotation. You have an opportunity to do this when they're very young, then you lose it. So.
Well, you certainly got us all fired up, Dr. Boyd, that's for sure. And I know you have so much to teach. I just want to be mindful of your time too. I know you have another engagement at 9:15. I just wanted to keep you on track here.
Watch this last video, and I can call it a day.
So we, on the back of encouragement from Jim Heckman, the Nobel laureate that was featured in that short clip, decided to look at the long-term sequelae or the consequences of having different levels of this thing called self-control in childhood. We measured it multiple ways. The researchers among you will know that any particular approach to measurement has some error, and the way you deal with that error is you triangulate. So we had 4 sources of information that were assessed at age 3, 5, 7, 9, and 11. So multiple time points and multiple sources, a very robust composite measure of variation on this thing called childhood self-control. Those are the types of questions that were reported on by the various sources. Hope that makes sense in terms of how you would operationalize this idea of self-control. Then we related variation on that measure, and basically it was a normal distribution. So some people had a little bit of it. Then we had a bunch with respiratory problems. When we combined all that and said, what's the relationship with childhood self-control? This is what we saw. Now, the way to read this graph, and I'll take you through the first one because
and really, I'll just summarize it for you, is that if a kid has got poor self-control before the age of 9 years old, it's almost 100% predictable that these kids are going to have very short health spans. They're going to be very sick. A lot of them become addict. They have substance problems. Some of them have just really bad behavioral problems. And I'm scratching the surface of this, but I want that to be the last thought in your brain, is that if somebody gets in your way of wanting to expand a kid with transverse sagittal deficiencies and comorbid behaviors with sleep and breathing, that's very wrong of what they're doing. They could be getting in the way of changing a child's life. I take it that seriously. So thanks for the opportunity. Thanks for coming here. Hope to see some of you more. You have a million great questions, and I obviously won't get to them tonight, but we'll plow through them at some point.
Yeah, I can't thank you enough. I love the developmental dentist. I love the call to action. I love how you're empowering general dentists and pediatric dentists, as well as orthodontists, to jump on board with this. This is archived, everybody. So I know there were a lot of questions about how to share this with medical colleagues as well as dental colleagues. So we have a YouTube channel, all of our expert talks are on there, and we will send you the link where you can have all this information to share with anyone you feel would be appropriate. I do want to talk about your upcoming courses, Dr. Boyd. We have one on December 10th. We're going to just be a call to action, and you can see, you don't even have to take the course to see the call to action, why it's imperative after your talk tonight that dentists really have an opportunity to change healthcare as we know it. So I'm so excited about that course, December 10th, and also January 14th. It's just talking about enjoying treating kids. I think a lot of general dentists in particular may be afraid of children because they're not used to it. So you do such a nice job about connecting the dots and really getting your tools and tips and tricks. Any words about your courses that you want to share coming up?
Not just that deal in Seattle in June. I'll get people information about it because it's all physicians. I'm the only dentist, even though there's a dental component, and it's not directly related to the Dunedin study, but tangent. But I would really like them to open up the opportunity for non-physicians to come to this. And, you
just froze there. So I'm just going to go on with our next.
Anyone wants to come.
Sorry. You froze there. So any information about that, of course, we will keep everyone posted in the emails and updates, and that would be wonderful if that was opened up for dental professionals. I got a lot of questions on how to implement this in the general practice and the pediatric practice. We love Dr. Moralia's pediatric mini residency, November 12th. We do have a couple of seats left. We make this class size very small on purpose, so you get a lot of interaction. So please consider joining us for that or reaching out for me for more information. Dr. Boyd, I know we didn't have a chance to talk a lot about myofunctional therapy this time around, but I know you don't do treatment without it, right? It's part of your comprehensive care. So I think you could touch on that a minute.
Yeah, every kid now, and it's gotten to that. I recommend a myofunctional evaluation. I haven't yet built it into my fee structure, but I probably should. It's just part of the deal because some people, I can't afford that. This is already costing too much. It's so valuable. And I've gotten very good at assessment and getting them. And I've got a wonderful Jody Walker who comes to my office, every week. And you just have to make it part of your practice with kids anyway.
Well, we created a course with Brittany Sierra and Caries Laguerre to teach the hygienist in the general practice to do myofunctional therapy. But the course is also great for existing myofunctional therapists because it's really like a workshop. So please feel free to visit airwayhealthsolutions.com/myo. Again, I would love to chat with you if you're interested. There are a lot of parents on the call today. So if you don't live by Dr. Boyd or Dr. Mariah, go to our airwayhealthsolutions.com/locator. Also for our SLPs and RDHs who are looking to network with like-minded airway dentists, please search that map coming to you. And we have upcoming conversations coming up with Dr. Jasmine Elmore and upper respiratory resistance syndrome. And then your friend, Dr. Gerald Simmons, also on the task force with you December 1st about screening, monitoring, and management of childhood and adult OSA. So we're really excited about that. I'll go ahead and take any emails that if you wanted to get in touch with Dr. Boyd, we will give you some follow-up information. But again, if this is all archived on our website, airwayhealthsolutions.com/webinars. So you can share this with your colleagues as well, or feel free to give me a buzz. Happy to chat anytime. Okay, so what a night. I mean, my head is spinning. I know I'm going to watch this over a couple of times because, again, you gave so many pearls, and thank you for all you do. Thank you for your persistence. Thank you for being fired up and sharing that. You really energize people by your passion, and I can't imagine the number of children's lives you've saved and lived healthier lives from the work you do. So,
well, thank you, Lauren, for your skill and for this. You have a great audience. You have a great following. I'm honored to be part of this whole project of yours. So,
well, until next time, as I said, we'll keep showing up. As long as people are still interested, we'll keep showing up. So thanks, everyone. Thanks, Dr. Boyd. Have a great night.
Thank you. Good night. Good night, everybody.